Assalamu alaikum. Good afternoon. So this is a light-hearted session. We're all going to be nice, calm, and collected. Working with Hussam Noor is like a dose of fentanyl. Nice and calm and collected, and we're all very relaxed. So we're going to talk a little bit about complications in CTO. So we are getting better at treating CTOs. We, all of us, right? Better operators, more experience, more proctoring, more training, more fellowships. We share experience and our success rates are rising, all of us. At the same time, our complication rates initially improved but are now stagnant. So recently published by Progress CTO, the success rates in top centers in the US is somewhere around 88%. That is spectacular, actually. If you look back 20, 30 years, an 88% success rate in CTO PCI is very high, even compared to 5 years ago. They've gone up from 81 to 88%, despite increasing complexity. MACE at present remains stagnant at around 2%. So as we start to look at registries, the majority of data comes from registries. There is a significant complication rate, some of which are very major, some of which are less major, but there is a complication rate. Mortality is nearly twice as high when you compare to similar patients on an NCDR database. So you have elevated mortality in CTO PCI. Angiographically visible perforations is about 9%. Important perforations is just under 5%. So more mortality, more perforations. As we look at the registries, we start to look for predictors of complications. The retrograde approach on its own doubles your complication rate. Right? Just going retrograde doubles complication. Increasing age makes sense in everything. As we get older, things are more difficult. We have higher complications. And an elevated JCTO score in this particular registry, so it kind of makes sense, right? So more complex disease, more difficult disease, a higher level of complications. As we start to look at other registries, and one of the larger ones, also documented an in-hospital MACE rate of nearly 2%, and a perforation rate of nearly 4%. So, and as we look at more and more registries, we're looking at perforations somewhere around 4 to 5%. In this one, again, the number one leader is going retrograde. So significantly increases your complication risk, increases mortality, increases perforations and tamponade. Importantly, in this one, JCTO score didn't seem to be such a big predictor, but retrograde is a major predictor. Now, say you have a complication and your patient does well and goes home. Just by having a complication, the 12-month mortality is 4 times higher. Interesting, right? Furthermore, the symptoms are even worse. So it is very, very important that we realize that this is a procedure that has a higher than normal risk. You compare non-CTO PCI with CTO PCI. Higher mortality, higher myocardial infarction, higher emergency CABG, higher rate of perforations. And this is an elective procedure. This is not a primary PCI for STEMI, this is an elective procedure. This means that we should be prepared, right? We should be prepared as an operator. You need to be not just mentally and physically prepared, spiritually prepared for complications. We need to be prepared as a cath lab team. So you're not a lone wolf, you're there with very experienced nurses, radiographers, technicians, people around you, and quite importantly, as an institution, the right setup, the right equipment, the right colleagues around you should things happen. So this is in our hospital, this is our perforation cupboard. And it's very important when things happen that you don't go look around lab 1, lab 2, lab 3, find me the pericardial drain from here, find me some kind of coil or delivery system from there. Things should be somewhere where everybody knows where they are and you can get them very quickly. It's important to have some kind of mechanical support available, should you require it. Not everywhere will have ECMO and Impella, but some kind of support, maybe even a balloon pump available. And really, if we're doing CTOs, and especially more complex CTOs, we have to have cardiac surgery on site in case you need somebody to help bail you out. So let's go through a few cases. Do be nice to me, because some of these are mine, some of these are not. So this patient came to us from another center, right, where he had a non-STEMI, the culprit being this tight circumflex lesion, and they found the CTO in the LAD. Now this is a non-CTO PCI center, non-surgical center. They went femorally with a single guide, no contralateral imaging. Here's the CTO, here's the retrograde collaterals from the LAD. The CTO goes all the way up to the LAD, the proximal LAD. They took a wire, I think pilot 50, then pilot 150, tried their luck with a balloon proximally and got nowhere, and this is how it ended. So even though this patient was thankfully hemodynamically stable, he still had ongoing unstable angina symptoms, post-non-STEMI from his circumflex, maybe from something that happened in the proximal LAD as well. I'm not sure. So he was referred to our center for urgent cardiac surgery. We did a heart team MDT, and we felt, you know what, we can probably rescue this LAD, and we can probably try to do PCI to the LAD, and if that fails, we'll then take him for bypass surgery. So here we went retrograde. There was a large hematoma antegrally. We took a decision to take a pure retrograde approach. Hussam will tell you, Khalid will tell you, going from the LAD to the RCA is not so difficult. Going the other way around can be challenging. There's a lot of these tiny little collaterals, and finding the right one will take some time. So we try first, second, third, fourth, fifth time, eventually find the right collateral that gets you to the LAD. Once we get there, it was relatively straightforward. So we approach it retrogradely, we wire into a guidezilla, and then externalize and do our image-guided PCI with a good outcome. And the lesson learned from this case is no shortcuts. If it's a CTO, you need to be a prepared operator, you need to be in the right center, you need to have the right equipment, and you take two guides. No, let's try our luck with one guide and maybe it'll go through and save a bit of time with the access. So this is one of my cases, and every one of us will have a sentinel case. This is from 10 years ago, roughly, where you learn a lesson and you do something that you will never do again, right? So this patient came in for elective PCI to the right coronary artery CTO. Very symptomatic, lots of ischemia on MPI. And our plan was to go, to do our usual CTO PCI. So we've got two guides, one in the left coronary, one in the right coronary. We start our antegrade wire escalation over a microcatheter. Have a look at my left guide. So as an operator, you're focusing on what you're doing. There is no safety wire in the LAD. That's the last time I have ever done this. Yeah, there is no safety wire in the LAD. You take your eye off the guide, the patient takes a big breath in, the patient moves, the patient does nothing. The guide itself just migrates, and so all of a sudden your guide tip is touching the ostium of the LAD. So as you tell your assistant to give you a small test to see where your wire is from the contralateral approach, you look up and you see this dye hold up in the left main stem. Now, thankfully, this patient was stable. The hematoma wasn't big enough to cause ischemia, and it was relatively easy in this case to wire with a workhorse cyan blue, and we do our IVUS and we do our IVUS-guided stenting. It could have gone much worse. Sometimes you have a massive hematoma that you can't get past, and if it's the left main and the patient crashes, you've only got yourself to blame. So always, always, always safety wire in the donor vessel, and watch that contralateral guide. Keep a close eye on it. We did IVUS-guided stenting, stented the LAD in left main. The patient was stable and remains fine today, but you go in for PCI to the right, you end up with a stent in the left main, and that's something that's potentially avoidable. Perforations, Hussam mentioned this earlier. Questionnaire to all of the CTO operators, and actually even non-CTO operators. What is the single thing that concerns you the most in all PCI? And it's always perforations, right? This is a site that you never want to see. And there are three different types of perforations. This was mentioned by my esteemed colleagues earlier, so I won't dwell too long. Distal vessel perforation or side branch perforation, main vessel, and collateral perforations. Distal vessel perfs tend to happen because you have a high tip load polymer jacket wire. These are notorious for giving you very little feedback as to what's happening distally. You're in a small side branch, you're at the very distal end of the vessel. You have these very fine wire movements. You don't necessarily have to move a lot. When you're moving your balloon in and out, when you're moving your microcatheter in and out, a tiny little millimeter, sub-millimeter movement can actually cause a perforation, and quite often goes unnoticed throughout the case because the wire tip is covering it, so you can't really see what's happening. Main vessel perforations can happen when your wire is outside the vessel architecture. Now, when the wire goes outside, you're fine, as long as you don't follow it with anything. Once you take a microcatheter or a balloon and you start inflating outside, as was shown earlier, that's when you start to have problems. Oversizing your balloon. So in a CTO, you have a lot of negative remodeling. It should be a 3.0 vessel, but actually it's now a 2.5 vessel. You take what you think is the right size balloon and you've oversized it, or the stent. and aggressive post-dilatation. Now, say you've gone subintimally for part of it, and then you start to aggressively post-dilate, you can actually cause a nice little perforation, and our good friend calcium. So how can we try and prevent these scenarios? Well, watch your wire. If we don't know where the wire is, if we can't see contralaterally that we're somewhere reasonable, we should not follow with equipment. We use contralateral injections, and as soon as you've crossed and you're distally, try to swap out for a workhorse wire, a safer, lower tip load wire. I personally like to trap all of my equipment. I think that's the safest way to prevent any movement, so I use a trapping balloon whenever I move in and out. Imaging is always important. I'm a big fan of imaging for all cases, but in CTOs it's even more important. You confirm where you are. You confirm you're in true lumen. You confirm where your wire went. It's sometimes very difficult to know if you went true to true, if you went subintimal then true, or in and out and in and out. So it's worth finding out where you've been to know how aggressive you need to do. And you can understand the calcium. You know, is there a big lump of calcium? Is it concentric calcium? Is there a nodule that you can't see angiographically? Because we miss a lot of nodules angiographically. And that tells you how to go. Use heparin, no bival, no GPI in CTO. And finally, I'd say take a long, hard look at the angiogram and actively look for a small perforation. It won't show itself sometimes. This is one of my cases where we take a wire, it's a Fielder XT, it's not even that aggressive, but you take a wire to the distal RCA and we do our PCI procedure, and at the very end of the procedure, this is the final coronary angiogram. Hassam, can you see a perforation? You see it now, right? You can see it now because we're looking for it. But I missed this, I couldn't see it. The patient was fine, stable, not tachycardic. They can see the heart rate's perfectly normal. Blood pressure's normal, but 4 hours later, I come back to put in a pericardial drain. So, you know, it's always worth actively looking for it. So this is an algorithm, well published. This is something very similar to what we've gone through. What happens in our cath lab is the moment you see a perforation, you need to say the word, there is a perforation, and there needs to be absolute silence in the room. Right? Because it's all hands on deck. Everyone needs to pay attention and everyone needs to focus with you. And you're doing a lot of things at the same time. Now, the first thing that you think of is bad, right? Hassan mentioned it, bad. Block and deliver or balloon and deliver. You try and control the situation and buy yourself time. You call for helps. You call for your colleagues, the surgeons, and other interventionists to help you out. Because one person in the room, when you're thinking of hemodynamics and you're thinking of coronaries and you're thinking of tamponade, it's nice to have a friend with you. You get your equipment ready, you get your team ready, and you get prepared to treat. So you'll see a lot of these slides. A lot of them are taken off Berlakis. Berlakis' book is fantastic, and I think it simplifies the way we look at things. The moment we see a perforation, we stop feeding it, right? So now you've got something that's letting blood leave the coronary, you stop giving it blood. You balloon proximally to it, you balloon on it, but you stop blood going through it. And that buys you time. You get your second access. CTO cases, almost always we have a second access anyway, but you get your second access and you start to use your second access to deliver your equipment. So if you think about it, you've got your wire and your balloon in the vessel, blocking entry into the perforation. Every time you want to do something, you want to put a covered stent, you want to put a coil, you don't want blood to rush in. So you deflate temporarily, pass your equipment and inflate again. And then you can either use your fat embolization or your coils or your covered stent if you need to. Septal perforations tend to be benign. The vast majority of the time, they're self-limiting. So if you go from LAD to RCA in a septal and you see a small perf, you're usually okay. But some do progress and some do cause dry tamponade, and I'll show a little case earlier. Epicardial perforations can be disastrous if you don't treat them straight away, and they can be more difficult. So, how can we prevent this? Study the angiogram well beforehand, understand where you want to go, understand the vessels, know exactly what's happening, which is why we don't do ad hoc CTO PCIs. Be very cautious with microcatheter tip injections. I personally don't inject. A lot of colleagues do, I think Hassam does, but that's perfectly fine. But you need to make sure you're not wedged, because it's a tiny vessel in there, right? You may be wedged against something, and you may cause a problem when you're doing it. Unless you see where your guide wire is, and you're absolutely certain you're somewhere within the vessel architecture, we don't follow it with a microcatheter or a balloon or anything like that. We don't periodilate epicardials. We never touch epicardials. We use a very soft microcatheter in epicardials. And more importantly, if you've gone retrograde, keep the wire in place, keep everything in place, and do a very detailed angiogram and look for a perforation. Because if you perforate a septal and you've lost your wire position, you make your life much more difficult. So if you have a perforation in a collateral, remember the collateral is getting blood from two sides. So you have to block both sides, right? And you have to, either you apply suction, you collapse it, or you put you put a coil, or you block entry into it. So, a few cases. This is one of my cases, a retrograde CTO, PCI, the RCA, went swimmingly well. At the end of the procedure, when the wire was still there, we took an angiogram. We saw this very small septal hematoma. I was very comfortable leaving this. The patient's perfectly fine and stable, but you keep them on coronary care because they can become unstable potentially. This patient remained well and he went home. But there are cases where they will continue to grow. So this patient had a very similar PCI with retrograde collaterals, and he found this hematoma that appeared to be self-limiting, but a few hours later, the patient got more chest pain, became unstable. You read the angiogram, and the septal hematoma is growing. So they go from both sides, from the LAD side, from the RCA side, and they block inflow and outflow using coils. But a few hours later, the septum kept expanding and the hematoma kept expanding. And this caused dry tamponade. So what happens here is you have a very large septum that's effectively starving your RV from blood supply. And in this case, we don't have this in Saudi Arabia yet, but they used an Impella RP to offload the right ventricle and gave themselves some time for the hematoma to settle and the patient to stabilize a few days later. In our institution, we probably use ECMO in this scenario, as I'm sure many other places would. This patient, again, had the similar outcome where they had a hematoma, and the operators go from both sides. From the LAD side, they collapsed the collateral with negative suction. From the RCA side, they deployed a coil, but this didn't work, so they had to put a covered stent to block flow into the collateral. Now remember, if you're coming back the next day or a few hours later, and your wire is out and you want to try and close a collateral, there's a lot of little collaterals. And can you really be certain that you blocked the right one? It's probably very difficult to do so. So in summary, complications are common in CTO PCI. We have to be able to recognize them. We have to understand how to manage them. Proper preparation prevents poor performance. The right setup, the right team, the right equipment, the right environment, and the right mindset. And we have to be aware that these things will happen. Not a single CTO operator can say that they have no complications. You don't be too hard on yourself. Don't be too hard on your colleagues if it happens to them. This is a very difficult situation to be in. We will all grow and learn together. And hopefully, as we get more and more time together, more experience together, our complication rates will continue to improve, and we have better outcomes for our patients. Hussam.